All right. Hi, everyone. Welcome to the NAMI Lunch and Learn series. I am delighted to introduce Dr. Susan O'Neill. Susan is an associate clinical professor in the Department of Psychological and Brain Sciences here at the University of Iowa. She trains graduate clinicians within our doctoral program in clinical psychological science. She has extensive experience as a therapist, a skills trainer, and a clinical supervisor within a full model program in dialectical behavior therapy, or DBT, which she'll be talking about today. This is an intervention that was specifically designed for folks with borderline personality disorder and borderline personality characteristics. Susan is passionate about increasing access to evidence-based care and reducing stigma for individuals with emotional and substance use disorders. In addition, she is interested in the use of mindfulness and compassion skills to increase resilience in healthcare providers. Susan is the proud mom of a teenager, and she also has a puppy named Rocky. Thank you so much, Susan, for joining us today, and take it away.
I really appreciate the invitation to think with you all as a group today. I invite you to share your thinking in the chat as you're comfortable, okay? At certain points you may unmute your mic or share your face, but I hope that we can do some thinking together as a group in addition to you hearing some information from me that I hope is helpful. So I've titled my talk about BPD and dialectical behavior therapy, A Life Worth Living. And so a key assumption of this presentation is that life is in fact worth living. I believe in the inherent worth of each person and the preciousness of each of their lives. And that belief, that commitment has really guided my work over the last 20 years, both as a full-time clinician, as a part-time clinician, as a DBT therapist, skills trainer, and supervisor. So this work is essential. It is an essential part of the life that I experience as worth living. So thanks for allowing me to be here today and be in alignment with the life that I'm hoping to live. So if you would, we all get invitations to attend online and in-person trainings. Our inboxes are deluged with them. But for most of us, a lot of those invitations, even some that are interesting, end up going straight to the trash. So something made you register for this Lunch and Learn. It made you open the emailed message with the Zoom link today and to set aside this time. And that took some real effort, and I appreciate that effort. And I want to make sure that the effort is worth it for you, or to at least try and increase the likeliness that that's true. So my question for you is to take just a moment and ask yourself, why are you here? Why are you at the Lunch and Learn today? Just noting it for yourself. Yeah, learning to support your son. Yeah, stigma and just difficulty in everyday life. So now I invite you to think about why you're really here. Think of it. Why are you really, really here? Not just the first thing that comes to mind, but like way down there in your gut. And some of you may have already shared that, but sometimes it's helpful to think about, okay, what am I really up to here? So I can share why I'm here. I'm here because a colleague invited me. I'm really here because the university likes faculty to do outreach. And I'm really, really here because I care about people who have disinhibited emotions and behaviors. And I really care about how they're treated. So I'm talking with you is just a small way that I can help chip away at the stigma that people with suicidal and self-harming behaviors, BPD, substance use disorders, to chip away at their self-stigma, public stigma, and then also institutional stigma that people with serious mental illnesses experience. So now, if you would, if you're willing to do a little bit more reflection, think about what you already know about borderline personality disorder. And that might entail just noting 3 words that come to mind when you think about BPD. You might think about 1 fact that you know about BPD. Or you might describe someone you know who has BPD, or if you are on the borderline personality spectrum yourself, what's 1 thing you'd like other people to know about people with BPD? So Liz says they are difficult, manipulative. I have a hard time having compassion, just want to avoid them. That's the first thing that comes up for Liz. Thank you. Fear of abandonment, not a mood disorder, difficult to treat. Thank you. These are a lot of the things that first come to mind. Labile emotions, yeah, emotions that go up and down, emotional reactivity, emotional instability, struggle with secure attachment. Thank you. It's clear that people know some things about BPD and that there's a lot of immediate thoughts and images that come to mind. The only person more miserable than the people around someone with BPD is the person with BPD. Yeah. Yeah, it could be really hard to be around someone with BPD. And if that's the case, imagine what it's like to actually be inside their skin. So let's talk a little bit about this idea of a life worth living. Many therapeutic approaches use this language or similar language to help clients identify what they really, really want in their lives and how therapy can be helpful in getting them there. So exploring values, setting goals, making commitments to engage in specific behaviors towards change in one way, shape, or form. All of these activities are at the heart of many evidence-based interventions with broad applications, including motivational interviewing, behavioral activation, and acceptance and commitment therapy. So it is not as though only DBT talks to people about a life worth living. In fact, this slide shows a way that we can think about our own life worth living, but also to talk to other folks about what that might entail and building the life. In some ways, a life worth living is a little bit like a house. And you have to have a solid foundation, and our values, what really, really matters to us, the things that are kind of non-negotiable things, make that foundation. Over the course of our lives, we're all in this process of identifying what's foundational to us and securing people and things that will support us and protect us. We all have to learn how to manage emotions. We all have to take time to smell the roses and appreciate current reality, just in the moment. And we also have to learn how to blow off steam. And you may or may not be able to see this, but the image coming out of the chimney here in this house that someone has drawn for themselves shows that walking their dog, listening to music, riding their bike, or playing volleyball are all ways that they blow off steam. So this is something that we're all engaged in, this process of building a life worth living. But what if your house is on fire? What if you felt as though you were in hell? You might jump out the window of your house, even off the roof. If that was the only way that you could reduce your suffering or potentially save yourself, even if doing that, even if jumping out that window puts your life at great risk. The lives of suicidal individuals with BPD can be unbearable. unbearable, as Shauna noted, as they are currently being lived. It's as if they're experiencing agony from third-degree burns, suffocating, terrified. And this can be hard for those of us who don't have those experiences to imagine. And so we use metaphors that might seem extreme, like your house being on fire, your skin being emotionally burned. We use those metaphors to help other people understand what it's like to have BPD, but also to help people with BPD have some kind of language to talk about their experience. Dialectical behavior therapy was designed for people who experience this type of very intense emotional pain. And this intense emotional pain is of the kind that can make ending your life seem like the only option available to you. So when Marsha Linehan, the developer of DBT, when she talks about a life worth living, she's referring to something slightly different than the way we might use that term more broadly. She's referring for the need of people experiencing suicidal thoughts and behavior, self-harm behavior, or other experiences that can go along with BPD. She's talking about the need for these people to experience their life as worth living, as worth not taking their lives, right? So it's not just like, hey, where would I like my life to go? It's like, no, I have to have a very clear sense of why I am not going to take my life. So I have to build a life that is literally worth living. Let's hear Dr. Linehan talk a little bit about how DBT came to be.
The first thing we're going to cover is where in the world DBT came from. So I'm going to tell you how the whole thing got started. And it got started because at a much younger time in my life, I made a vow to God that I was going to get out of hell. And when I got out of hell, I was going to go back to hell and I was going to get other people out. That particular promise has controlled my entire life. And these skills came straight out of that particular promise. And of course, it happened first by me trying to treat people who are highly suicidal and people who experience their own lives as lives in hell. The goals of DBT skills ultimately are to help people build lives that they experience as worth living. All lives are worth living, so let's agree to that. But not all lives are experienced as worth living. And the whole point of DBT is to help people build lives they experience as worth living. And skills are a very important factor in building that kind of life.
Notice as we go through the presentation today that you'll see this little stop stigma sign, little hand that says stop stigma. And part of why I've placed that there is that it reminds me, and also maybe us together, to think about what this little piece of information that we just received, what it does to challenge stigma or what it does to reinforce stigma. So I'm wondering if people might be willing to share in the chat what they noticed about the video and how that video might challenge and or might reinforce stigma about folks who are on this continuum of experience. I'll give an example. I think that this video helps to reduce stigma because it represents a very successful academic clinician who disclosed her own struggles with BPD, right? She shared how her own experience of suicidal behavior, of hopelessness, how that contributed to this career that she's had. That's big. That's really big to jump out there like that. Sarah notes that the video acknowledges the autonomy of the person living with BPD. It reduces stigma in suggesting that there's maybe a good reason why people, or that maybe not a good reason, but that people's suicidal thoughts and urges make sense in the context of their experience. Yeah. Any way that you think the video actually reinforces stigma, or is to say that it's stigmatizing in some way? You may not have experienced it that way, but I wanted to make sure that we gave the opportunity to think about it. The only way in which it kind of occurs to me that it could reinforce stigma is that not everyone who has borderline personality disorder experiences suicidality. So it's possible that if you're somebody who has BPD, but suicidality is not part of what you struggle with, it might be difficult and potentially stigmatizing to have people have that be one of the very first things that people think of when they think of BPD. Thanks so much for sharing your thoughts. So let's talk just a tiny bit more about stigma. So everybody on this call is aware that stigma refers to negative beliefs that people have about those with mental illness, and that those stereotypes can translate into discrimination. Self-stigma is a really important part of the stigma puzzle, and it's probably what we think of first. Self-stigma is inversely related to self-esteem, to self-efficacy, and quality of life. It's hard for us to feel like we have what we need to do when the world is sending us message that there's something wrong with us. Women with BPD seem to be exquisitely sensitive to this experience of self-stigma. And there's some research conducted in the 2000s that looked at rates of stigma in women who had BPD relative to women who had social phobia. And the women with BPD had significantly higher rates of self-stigma than women who were struggling with social phobia. Public stigma, right? So those social attitudes and behaviors that are just in the fabric of the culture, right? So I don't know how many of you might be aware of this idea of the crazy hot matrix. And this image right here with crazy on one dimension and hot on the other. There's sort of this social media theory that has permeated beyond social media that suggests that as women get crazier, I should say, as women get hotter, their craziness goes up, and that others who may be attracted to them are willing to tolerate that crazy. So all women, this theory suggests, are at least a 4 on a crazy scale, and that as their hotness increases, so does their partner's willingness to tolerate the crazy. Believe it or not, there was actually a paper published just last year in a very prominent social psychology journal that tested this theory and found that, in fact, people do make these kind of assessments about women who are attractive, and also men who are not attractive but are wealthy. This is a really good example, though, about how public stigma about BPD gets out. In this research study, crazy was operationalized by using borderline personality traits, right? So this crazy hot theory is out there in the world. It actually has been absorbed into the research literature. And that reinforces people's beliefs, stereotypes, and can lead to discrimination. Many of you are probably familiar with the ways in which people with BPD experience structural or systemic discrimination. So BPD is highly stigmatized by healthcare workers. There's lots of research that shows that clinicians report that they may be less helpful or less likely to be helpful when they're working with someone with BPD. And also that clinicians may be more likely to use what we might call overly custodial interventions, which is probably a way of saying that people who have BPD are more likely to be sent to the emergency room, are more likely to be admitted to the emergency, to a psychiatric facility, and they may spend more time there. That may or may not be in their best interest, or it may or may not be indicated, but that people have these stereotypes about BPD that translate into the care that folks get. You're probably painfully aware of how difficult it is to find providers who are trained in evidence-based approaches to taking care of folks with BPD. These services tend to be not particularly affordable, even when we can find them. Insurance and other sources of funding are not adequate to deliver the type of wraparound care that we know can be effective in working with people who have BPD. Good news, there's also research to suggest that healthcare workers can be trained to develop less pejorative attitudes about BPD, and that may be something that any of you decide you're interested in chasing down. Let's talk a little bit about where this concept of the borderline came from. It was first delineated by Adolf Stern in 1938, a prominent psychoanalytic theorist. And this is what he had to say about a particular group of people. It's well known that a large group of patients fit neither into the psychotic or the neurotic group, and that this borderline group of patients is extremely difficult to handle effectively by any psychotherapeutic method. So Stern suggested that there are a group of people who fit somewhere in between a struggle with loss of contact with reality and the boundary of people who struggle with anxious and depressed mood. Note that these patients that he described did not respond to psychoanalysis. So in part, they're defined by their failure to respond to the prevailing treatment of the day. That might say more about the prevailing treatment than it does about the people that are being described. So as a science, we've moved beyond this type of classification that's associated with psychoanalysis. However, this idea of people with borderline personality disorder being extremely difficult and untreatable still is pervasive. Right. So let's talk a little bit about what we mean by personality and what we mean by disorder. When psychologists talk about personality, they're really talking about someone's unique constellation of characteristics and how those characteristics shape their experience, how it shapes their interaction with their environment, and how it shapes their adjustment to life. Personality can be comprised of traits, values, how people think about themselves, the range of their abilities, and importantly for our purposes, the emotional styles that represents part of an individual's personality. Some of you might be familiar with a particular model of personality, the 5-factor model. There are a lot of models of personality and ways of measuring personality, but for our purposes, we're going to look at just one. This model is widely used in psychological science. It's used to explore functioning and health behaviors. And one of the reasons why we use it is because it can be reliably measured, and it is valid in what it predicts of people's behavior. So we can use the acronym OCEAN for the 5-factor model. Let's just talk very quickly about what these traits represent. So openness to experience represents the degree to which someone is practical versus conventional, the degree to which they are curious and independent. Conscientiousness refers to the degree to which somebody is disorganized and careless as opposed to being dependable and organized. Okay. Extroversion refers to what most of you think of when you think of extroversion, being quiet and reserved as opposed to being outgoing and energetic. Agreeableness, which will prove to be one of the personality traits that we look at in terms of characterizing borderline personality disorder. People who are low on agreeableness can be critical and suspicious, and people who are high on agreeableness tend to be trusting and empathetic. Neuroticism, which many people also describe as negative affectivity, is also very relevant for borderline personality, understanding BPD. It represents the degree to which someone is calm and secure as opposed to anxious and unhappy. Thanks for the info, Amanda. So if personality is an enduring constellation of traits and behavior and inner experiences that shape how we interact with our environment and our adjustment to life, personality disorder just refers to personality traits and behaviors that cause significant distress or impairment for individuals. For our purposes, we're going to work with that very straightforward model of what it means to have a personality disorder. When we talk about borderline personality, it tends to have 3 facets. The emotional instability that some of you noted, an interpersonal instability, which is part of what can make being around people who have BPD challenging and also painful. Impulsivity, finally, is really the third characteristic of BPD that's important for us to keep in mind today. This screen is really only to highlight how little we actually know about BPD. So in this image, you can see that in 2003, less than probably 30 papers were published on BPD. The good news is that over time, those numbers have increased a lot. This is good news. But to give you some kind of comparison, in 2004, about 12,000 papers were published on depression. And in 2019, when there were about 400 to 500 papers published on BPD, there were about 4,000 papers on depression. Let's talk about what we mean specifically when we define borderline personality disorder in a categorical way, in the categorical way that's used in the DSM-5 and that's used every day in medical practice. You need to have 5 of 9 of these symptoms in order to meet criteria for BPD. I just want to highlight a few things about each of these symptoms and how we assess them, because you may be familiar with a lot of these. A lot of people think of abandonment issues when they think about BPD. But when we're assessing whether or not abandonment is at a level that is very impairing or distressing, we're really talking about people making frantic efforts to avoid abandonment. So a frantic effort might be taking the keys away from your romantic partner so they can't leave the house, or putting yourself between your mother and the door so that your mom can't leave a situation where you don't want her to leave. So it really has to do with these behaviors that people engage in. And we infer that they engage in these behaviors because they're concerned about abandonment. People with BPD have very intense and unstable relationships that can sometimes vary from an individual really liking someone and idealizing them when they first meet them, but then at some point reaching a point where they feel like they can't even have this person in their life anymore. They devalue that person in their life. We look for those intense relationships in more than one domain. So if somebody has a single romantic relationship where this is true, then we might say, well, we got to get more information or watch people over time to find out whether or not this is a symptom of BPD. But if you see it in romantic relationships repeatedly over time, or you see it in intense relationships with family members, friends, and romantic partners, or at work, that's the type of interpersonal instability that we're looking for. Unstable self-image is difficult to measure, and I'm not sure that it's that essential to understanding the core of BPD, so I'm not going to talk too much about that. I do want to talk about assessing impulsivity. What do we mean by impulsivity, particularly in people with BPD? People have to have impulsive behavior in 2 areas that can cause them harm, all right? Those areas may be spending, sex, substance use, reckless driving, binge eating. Those are the characteristic impulsive behaviors that we tend to look for. And people have to have behaviors in more than 2 of those areas, and drinking a lot and using drugs a lot only counts as 1 area, not as 2. So it has to be something else in addition to any substance use. People often talk about how do you decipher between bipolar disorder and the unstable mood that you can see in bipolar disorder as compared to borderline personality disorder. And it can be hard to tease out sometimes, but the key thing to keep in mind here is that the mood is unstable. It goes up and down. Sometimes people may be feeling really great, really energetic, and then within an hour, they're incredibly hopeless. But the important thing to note here is that that mood switching, moving from one to another, in BPD, it's usually that's only lasting for a few hours. And with folks who have bipolar disorder, you're more apt to see these changes in mood last for 2, 3, 5 days, 2 weeks. So that's one way to start to tease the 2 things apart. Chronic feelings of emptiness is difficult to assess, but what I will tell you is that this is a symptom that people, if they have it, they know it. If I ask them, do you feel empty much of the time? The lion's share of people will say no. But the people who say they do feel empty, they're very clear about it as soon as I ask them. If I ask them how much of the time they feel empty, they will almost always say higher than 50% of the time. So that's what we're looking for. Intense anger or difficulty controlling anger. So it's possible that someone could have BPD and only experience intense anger on the inside, but not display that anger in a way that's problematic. We sometimes see paranoid thoughts or dissociative symptoms that are transient. That's the important thing here, that they don't last, and they are triggered by stressful situations, right? So this is a way in which the paranoia or dissociation that you see in BPD is different than what you might see in a psychotic disorder or in PTSD. All right. Remember, there's a lot we don't know about BPD, right? So I'm going to give you this information in very broad strokes because that's about the best we can do. About 1 to 3% of the general population fit criteria for BPD, 10% in outpatient clinical samples, and about 20% of people who are in the inpatient population. The majority of people with BPD have co-occurring problems or disorders. That can make understanding how all these pieces fit together very tricky. A lot of people with BPD experience some type of self-harm behavior, suicide attempts. You often see PTSD and substance use disorders, and a lot of co-occurring depression. There's good news and there's not so good news regarding treatment. What we know is that we have treatments that work, and a lot of people, maybe about half of people who participate in intensive programs, decrease symptoms over even 8 years, 16 years, so long-lasting gains. Unfortunately, there are functional impairments that tend to persist over time, even when people's symptoms of BPD are a little better managed. So about 50% of people who meet criteria for BPD will have trouble with psychosocial functioning in the long term. So let's talk about, where does it come from? How does it develop? Marsha Linehan has a particular theory of how BPD develops that really focuses on 2 features: biological vulnerability that people come into the world with, and invalidating environments that are a poor fit for that biological vulnerability. These things interact reciprocally over time to increase people's risk of developing BPD. A couple things about that biological vulnerability. Sometimes it looks like, and it's experienced by people as being particularly sensitive to any stimuli that are emotionally relevant, right? So it doesn't take so much for someone with BPD maybe to become aroused emotionally. Their emotional reactions may be higher than what you would see with the average person, and it also takes folks with BPD longer to come back down to baseline after their emotional system has been activated. Often when people think about invalidating environments, they think about, well, what is it that parents do to lead to individuals developing BPD? And often that might be the place that clients go first, right? Thinking about people in their caregiving environment as children. I'll talk just a minute about how the environment is much bigger than any behavior from an individual caregiver. I'm going to share with you just a bit of information that supports this biosocial model that Linehan and Crowell have used to explain how it is that borderline personality traits emerge. So impulsivity and neuroticism, remember we talked about negative affectivity in the 5-factor model, highly heritable in individuals who later develop risk for BPD. We see that over and over again. Impulsivity is also associated with childhood risk for ADHD, oppositional defiant disorder, and conduct disorder. This is important when you think about how an adverse environment fits together with what someone brings into the world. Anyone who's parented an impulsive child or taught an impulsive child knows that that can be very challenging, and it doesn't always bring out our best responses. In schools, kids who are impulsive get a lot of messages about how smart they are, how good they are. The fit between that impulsivity and environmental experiences just increases the likelihood that people will experience emotional dysregulation, and that emotional dysregulation that they develop disrupts their learning, it disrupts their social and their emotional development. So impulsivity and negative affectivity work together along with the environment to put people at risk, and then to develop really entrenched behaviors like non-suicidal self-injury, or what we usually call self-harm, suicidal behaviors, substance use problems in adolescence. You do not need to think much about this picture other than just, I want to use it to illustrate that we tend to think of psychological disorders in categorical terms, and there are other ways to think about it, and in dimensional terms. When we think about BPD in dimensional terms, what we notice is that people with BPD have both internalizing symptoms like negative emotion, but they also have externalizing behaviors, disinhibition, and low agreeableness. You remember agreeableness is a 5-factor trait. Antagonism, which is in this model, is really just the other side of agreeableness. So let's talk a little bit about why DBT was developed and why it was developed to have particular features.
I started working with highly suicidal people. As it turned out, the people met criteria for borderline personality disorder, but A, I had never heard of borderline personality disorder, and B, I didn't know what it was. Even if you told me the name, I wouldn't have known. So that was the beginning of the whole thing. I had no idea what I was doing, except that I was studying suicide. What happened was standard behavior therapy of the 1970s and early 1980 blew up. And the main reason it did is because what it requires for it to work is for a person to come in and you be able to say, okay, here's the problem and here's what we'll do to change it. And for the person to say, okay, I'll try that. But the people I was dealing with immediately said, you're saying I'm the problem. And so they were so sensitive to any invalidation or statement that they were the problem that the treatment blew up. And they would either get angry at me, hide behind a chair, storm out, quit therapy, yell and scream, cry, or say they're going to kill themselves. So it didn't take me too long to figure out this was not going to work out. So I thought, okay, we're going to switch to a more acceptance-based treatment. So I'm going to validate and be very accepting. So I tried that. That blew up also, because then the patient said, you mean you're not going to help me? You're just going to listen to me? Most of the patients I treat have already been through a whole lot of therapy where you talk, get listened to, and understood. The problem is talking, being listened to, and being understood doesn't necessarily make anything change. So then they got really upset with me because I wasn't helping them change. So that's when I realized that I had to pull together a major emphasis on change with a technology of acceptance. So I had a technology of change, now I need a technology of acceptance. The technology of acceptance primarily was validation. So it's behavior therapy with a huge amount of validation. So problem solving, validation are the core components of the treatment.
talk a little bit about let's expound a little bit on what Marcia had to say. Let's get clear about what we mean when we talk about invalidation. As I said, it can be a communication between two people, and that's really how Marcia's talking about it in that video. So it's a way in which we communicate through our thoughts, our feelings, our actions, that another person's response or experience is not reasonable. It's not valid. We might send the message that somebody is overreacting, that their concerns are not worth our time, that their concerns or their experience is inconvenient, because sometimes their behaviors are inconvenient. But the fact that the behaviors are inconvenient doesn't mean that they aren't reasonable within the context of that person's life. On a bigger level, I'd like to suggest that physical, sexual, and emotional abuse, which are incredible risk factors for BPD, are sort of the ultimate invalidation of each person's fundamental human right to security. And so this is another way in which I think about how the world invalidates children in a way that can lead to the development of later problems. So if validation is the technology of acceptance in DBT, right? She said there's two sides, right? We have to balance the technology of change and problem solving with the technology of acceptance. Validation at its core is just communicating to someone that their thoughts, feelings, actions, and experiences make sense. And we can do that with our words, we can do it with our body language, and we can do it with our behavior. People often get tripped up about validation because they feel like, well, if I validate what someone else says or does, that's like saying that I agree with it, right? If my 12-year-old who's highly impulsive engages in a behavior that's really not effective, right? Like not doing their homework for a month. We can validate like, gosh, yeah, it sounds like you're starting to feel like no matter what you do, you just can't get the work done in this class. That's very different than saying, oh, honey, don't worry. It's okay if you don't do the work in the class, right? So we can understand where a person's coming from, even if we don't agree with or like what they're doing. We need to take a minute to make sure we don't leave today without talking about this dialectical part, right? What is it that makes this behavior therapy different? And one way is that it emphasizes dialectical thinking. You can see here the two dogs are talking about how many ways are there to skin a cat? And dialectical thinking recognizes that there are many routes to the same outcome. As a child, I heard my mom say many times, there are many ways to skin a cat. She's from a small town in the Midwest, so maybe that has something to do with that vernacular. But I think it's helpful. It illustrates that multiple things can get us to the same outcome. Another part of dialectical thinking is being able to hold the idea that two things that seem extraordinarily opposite can also be true. And not only can these opposites both be true, but further, there is a wisdom in each of those positions. And that if we want to be optimally effective, we need to honor the truth of those two things that are opposite, right? So here are some examples of dialectical statements that someone might make. I'm doing my best, and I need to do better. I need to try harder, and I need to be more motivated. I can do this, and it's going to be really hard. My mom is overprotective, and I also know she trusts me. So I think I'll talk to her about this hard situation. These are ways that we try and help people move to a more effective way of thinking. Let's talk a little bit about the structure of DBT. If someone participates in a full model DBT program, which and by full model, I just mean they get all the components that I'm describing here, individuals get weekly therapy. In that therapy, we do a lot more than just talking and listening and validating, although we do a lot of talking, validating, listening, expressing our empathy. But there's also a hierarchy of particular change targets that we're working on each week, and we take them in order. The first one being suicidal thoughts and behavior. Somebody comes in and they're reporting that they experienced suicidal thoughts or behavior on their diary card, which is just a self-report measure of how they're doing. If they report that, then that's what we focus on at the beginning of the session, every time. The second target is any behavior that's interfering with treatment. That might be a behavior that a client's engaging in, like always coming to session late, but it also could be a behavior that I as a therapist are engaging in, like always showing up late. And if either of these behaviors are happening in the client or in the therapist, we have to target that problem next in the therapy session using problem solving in a non-judgmental way. It's just saying, you know what? Being late happens. Let's figure out how we can get on time because that's what we need to do to get where we want to go. Maybe the most important part of DBT programs is this weekly group skills training. It serves two functions. You know, Marcia said that skills are really the way towards a life worth living, in many cases, the way out of hell. I'm going to tell you a little bit about what those skills are in just a minute, but this is a 2-hour session that people come to each week. They learn skills, they report on their use of that skill in the previous week, and then they get homework to practice it in the coming week. There is a weekly consultation team, which is fundamental to DBT as compared to other treatments. In a full model adherent program, you have a weekly consultation team that has everyone in the system at the meeting. So skills trainers, individual therapists, supervisors. We do this for two reasons. Therapists need support. All therapists need support, but therapists who work with intense individuals who struggle with suicidality or other impulsive behaviors particularly need support. The other thing is that team members use DBT with each other to make sure that we stay within our particular frame of balancing acceptance and change. People are often shocked to hear that we do phone coaching. Clients are really glad to hear that we do phone coaching, but it's important for me to say what that is. Each team member gets to say when clients can call them, when they can't call them, etc. And the phone calls are really skills focused. This is not therapy on the phone. It's asking someone, you know, what situation are you in? What have you already tried? And what could you try? In that skills training, there's 4 modules. Many of you may be familiar with these, so I'm not going to talk about them at length. Mindfulness has to do with being aware of what's going on with us in the current moment. I can't be skillful if I'm not even aware that I'm at risk for acting in a way that's not effective. Distress tolerance has to do with coping with those intense emotions and urges. Emotion regulation skills are about helping us decrease our vulnerability and increase our emotional resilience. And then interpersonal effectiveness is about how to interact with others in a way that help us get our objectives met. DBT skill, what do I want to leave you with? DBT skills are life skills. The skills work for clients, they work for people at BPD, but they also work for us. And DBT demands that both clients and clinicians use the DBT skills. I have included probably 4 of my favorite skills in each of those groups. Okay, think a minute. What did you get? What questions do you have? And what next steps might you take? Anything that you want to throw out here before we wrap up? How can we access DBT in Iowa City? Great question. If you'll see, the current slide says, what will be your next step? The university, hospital, and clinics actually have a full model DBT program, and you can access that care there. Actually, I should rescind that. I'm not sure if it's full model or just skills training. I think it might just be skills training as part of their intensive outpatient programs. Is that true, Amanda?
I'm not sure if it's full model or not, but I just learned as well that they have a DBT group for teenagers as well over at UIHC
Yeah.
Child Psychiatry.
Yeah.
So it's wonderful that that these resources are available.
Patty, thank you for this wonderful question. There is a companion program for parents of teens. When you there is a separate treatment for DBT for adolescents, and that treatment has both adolescent skills training and parent skills training, and it happens at the same time, right? So that that skills building can be reinforced and that parents can just get some support, right? Thank you, Patty.
I wonder if you could comment, you know, like when we think of personality, we think of personality as sort of it's fixed and it can't be changed. And I wonder, do you think that framework sort of contributed to the lack of research and treatment development for BPD?
Right. So not only were there these sort of stigmatizing ideas about the untreatability of these mostly female clients, right? But also this belief that personality is something that we form early and is stable over time. And what we know from research on personality in general, not just on personality disorders, that is actually personality can be fairly fluid. People can develop some parts of their personality and engage in programs to help them manage certain parts of their personality that are problematic for them, and DBT is a really good example of that. So it's a wonderful observation. I think that has a lot to do with the barriers that we've had to getting good treatment out into the world where it needs to be. On this slide, you can see, if you're interested in getting training in DBT, Behavioral Tech Institute is one of the sources for that. If you want to do one small thing today, put the 988 resource on your social media. Mention it to somebody. Just do something to help get that 988 suicide and crisis lifeline, that mental health 911. Help us get that out into the world. It's really amazing. Yeah. Absolutely. 17,000 papers on BPD since 2023. Yep. Things are improving all the time. Thanks for that, Libby.
With that note, we're at the top of the hour. I just want to thank you so much, Dr. O'Neill, for a wonderful talk. And I hope you'll come back again to provide another talk in the future. And we will make those links available for anyone who wants them. Thanks so much to everyone for joining us today, and we'll see you next month at the next NAMI Lunch and Learn. Take care, everyone.
All the best to all of you. Thank you so much.